This is the last session that I'm coming to do for the neurophysiology, and the other session about 8 to 9 sessions we made that Dr. Jafari will check with your time. Therefore, this is the last session. However, we have another part in neurophysiology, and it's a practical part. For the practical part, I will set the time with the disability and let you know when you should come to the School of Medicine, the lab. And we will show you some experiment to explore these functions that we told you in the class. I will wait for, I think, 1 to 2 weeks later, and the time, I will set the time with you. Okay. In this last session, I'm going to discuss about the pain. Before, you remember I told you about the somatosensory cortex, and I told you that the somatosensory cortex is not normally the same. It depends on the activity of our it depends on the activity of our skin receptor. Therefore, in human, that hands, particularly fingers, particularly index finger, is more in use. Therefore, the receptors are more dense. Therefore, in the cortex, this area is represented in larger area. And on the other hand, lips and tongue also is greatly represented. But in other area, it is not. And this is true also for other animals according to their life. Okay. And I told you also that, and this is the shape that we have in our brain. This is the shape we have in our brain. And you see very, very large hands, very small legs, and very large lips. Okay. You remember I told you also about the somatosensory cortex. If the somatosensory cortex is not working, therefore the activity will be, the motor function will be damaged. And this is an example of TAPS dorsalis, or disruption of the cortex by chemical disruption. As you see, in normal situation, animal is able to make the hand similar to this funnel and grab the food, but when the cortex is not working, you see, the motor function is not organized. And this is showing how much somatosensory cortex is working. Also, I told you that we have two somatosensory pathways. One pathway was because was not crossing the spinal cord. They enter the dorsal column, and without any crossing, it go to the mesencephalic area, to the medial lemniscus. And another pathway was coming into the spinal cord, make synapses and go to the other side, and in the other side they will go back. We have dissociation between our sensation. The detailed sensation of the skin, such as vibration, texture, and so on, will use the dorsal column, and there is no crossing. But on the other hand, crude sensation will make crossing to the other side and then go out. There is a case that is very interesting, and this is named as Brown-Séquard case syndrome. Brown-Séquard syndrome is when the spinal cord is being damaged, not completely, but partial. For example, left side of the spinal cord is being damaged. You can imagine what is happening. On the one hand, the nerve fibers that are coming from the crude sensation, pain sensation, temperature, that cross from the right side into the left side will be stopped. Okay? Therefore, we say they will have not any pain and touch sensation, crude sensation in the right leg, but because the dorsal column is working and the right leg, in the right leg, the dorsal column is do not cross, this leg has a detailed sensation. Detailed sensation remains. It is not completely insensitive. On the other hand, for the leg, for the left leg, because the dorsal column is being damaged, detailed sensations such as vibration, texture, point-to-point discrimination will be lost. But because from the right side, the fiber do cross to the left, from the left side, do cross to the right side, therefore this remain intact. In the left leg, the crude sensation remain. You can see that it is a mixture of this, situation. This is named as brown sequoia syndrome. For the last part of the section that I have with you, I am going to discuss about the pain. You know, pain is a sense. Several years ago, it was believed that pain is no sensation. Pain means extreme sensation in anything. For example, temperature. Extreme temperature means pain. Extreme pressure means pain. Extreme acidity means pain. Extreme light means pain, but it is not. We have a separate concept named as pain. And now what is pain? What is the definition of the pain? And what do pain for us? This is a standard definition that we have for the pain. And this says that pain is unpleasant sensory. Please pay attention. Unpleasant. This is not pleasant for us. Nobody can say that I enjoy pain. I enjoy feeling pain. This is not true. For everybody, pain is unpleasant. For everybody, pain is conscious. Somewhere I wrote conscious. We do not have unconscious pain. All the pain will be sensed by our consciousness. And also, it has emotional response, emotional experience. I will talk about it. That is associated with actual or potential tissue damage. Just in situation that we have a damage, the pain will be sensed. In fact, pain is not extreme sensation. Pain means damage sensation. Every time that damage is being happened. And you know, pain is important for us for several reasons. As I told you, pain gives us awareness, conscious awareness about the pain, about the tissue damage. And this is extremely important. Because when you have a pain in your body, you are aware of it and you try to remove the reason, the cause of the pain. You make you to find a treatment for the pain. And you know, if we were not aware of the pain, it was very dangerous. Somebody was dreaming of the life without pain. They say all the time, if we were able to remove all the pain around the body, if we were able to have not pain, it was extremely, life was extremely good. And you know, this is impossible. Life without pain is impossible. immediately the person will die. Because there are some damage and we are not aware of it. This damage will kill us. Imagine if the pain in muscle was not available, if the pain in the skin was not available, if the pain in the heart, you know, even sometimes some minute is enough to kill the person. Therefore, pain is a نعمة من الله. You know, and آمن نعمة من الله شكرا واجب بأعلى درجات. Okay. Without pain, life is impossible. You can imagine that I have no touch sensation in my hand, and I am continuing my life. We can imagine life without visual sensation. We have blind person. We can imagine those who are deaf. We are not hearing anything. But pain, without pain, life is impossible. And it is believed that we should always be praying God for having this name. Okay. Pain allows us to protect ourselves, remove ourselves from the danger. It allows us to promote and seek treatment for it, and also avoid the stimulus. You know that pain is very strong in generation of condition. You know that pain is very important for generation of condition. If we encounter a situation that is painful over time, we try to not go there, to avoid from there. And you know it is also working for animals. When we want to make the animals shape the behavior of animal, we use pain. An animal try to avoid the pain. If you put a food in a cage, an animal learn that every time that I enter this cage, there is electrical stimuli, painful stimuli. The animal will avoid to enter this area. This is mean pain condition. And therefore pain allow us to avoid from painful situation. And also it generates some behavioral and emotional responses that I will discuss about. What is the reason for the pain? Firstly, it was believing that pain is because of extreme sensation, but then it was found that there are some receptors, nerve fibers, free nerve endings, that they are sensitive to changing the chemical situation of this area. This could be in the skin, in the heart, in different area of the body. These receptors were named as nociceptor. Please pay attention. Nociceptor. Nociceptor means pain sensors. Okay. These nociceptors are sensitive just to the damage. For example, there is a damage to the tissue. These cells are releasing the potassium ion because the cells are dying. Therefore, release the potassium, release the serotonin, bradykinin, the hydrogen ion, the prostaglandins are being released, and therefore, and also activate the mast cell in this area. For example, the skin. All these factors will stimulate the nerve ending, and if they were enough, they generate action potential. This action potential will travel to the brain, and we will feel pain. In fact, we say that nociceptor activity is being perceived as the pain. If I stimulate this nerve fiber in your skin, you will feel pain by any reason. Okay? And this is an important factor. You should know that pain is generated by these factors. And you know one way to relieve the pain, to stop the pain, is to stop generation of these factors. For example, prostaglandins, bradykinin, histamine release. And you know some drugs that we are using and is used for pain relief, such as ibuprofen. Everybody have in your bags and your package. Ibuprofen, acetaminophen, aspirin. You know that these drugs prevent this step. Generation of the activity in the nociceptor at the beginning. Okay, therefore we can say that nociceptors are activated by these factors and then send the information to the brain. Let's see this figure. This is a pressure that is applied to the skin. But because the ending is blunt, there is almost no sense of pain. There is no activity because it is blunt. But when it is sharp, now the same pressure generated, particularly at the beginning. When it becomes a pinch-like stimulus, that it is more painful, you see the activity of the nerve is increased. And brain will consider this number of action potential as intensity and will say that this is more painful than this, and this was not painful. Okay, now, you see that when there is a tissue damage, when these factors are generated, it depends how many nerve fibers are activated. Sometimes the tissue damage is very, very slight. And just a few fibers are activated. It's very clear that pain is have low intensity. But when it involves a large area of the skin, therefore lots of nociceptors are simultaneously active, then this will generate severe pain. Therefore, severity of the pain is detected according to two factors. One, action potential of each nerve fiber. Second, this is named as temporal summation. And another is the number of fibers that are activated. You remember about the sensor system. I told you that when we have just a point, a few fibers are active. When it is larger and stronger, larger number are active. It is also for the pain. It is also true for the pain. When we have a pain that is affecting a larger area of the skin, it is more intense. And you know, when nerve fibers are activated by noxious stimuli, it releases some factors such as substance P, and substance P affect the vascular system, capillaries and arterioles, and this allows the blood flow to this area increase and generate inflammation, reddish, and getting the skin reddish. Okay, and this is named as neuroinflammatory, neurogenic inflammation. Neurogenic inflammation. Inflammation is generated because of the activity of neurons and generation of these factors. Okay. There are some other pains or other inflammation. Pain also have different types: inflammatory pain, mechanical pain, chemical pain, and this is also working. Okay. Firstly, it was believed that there is one type of receptor for the pain. Every factor that generates damage will be considered as pain. But then it was found that there are receptors that are different. We have some receptors or nociceptors that are mechanical nociceptors. They respond to mechanical damage. There are some thermal nociceptor. They respond to the damage that is generated by that temperature. There are some chemical nociceptors. They respond to chemical change. And also, we have receptors that are named as polymodal receptors. Polymodal means receptors that respond to different type of stimulus that generate the damage. Regardless of the type, all of these receptors respond to damage, but with different origin. Pain also is not the same all the time. We have some superficial pain that is coming from the skin. We have some deep somatic pain that is coming, that they are coming from the muscle, joints. Everybody has this experience. When you do exercise, after the exercise you have a pain in your muscle. And this pain is not because of the damage. It may be because of some damage, some small damage, but mainly because of the acid lactic that is filled or accumulated in the muscle. Also, we have visceral pain. What is the visceral pain? Visceral pain means the pain that is coming from the intestine, the heart, kidney, bladder. This is named as visceral pain. And you know that visceral pain is poorly localized. Poorly localized. I mean, when we have a problem with the skin, we are able to say, I have a pain in my right hand, right index finger. But for the visceral pain, localization is very poor. You can say, I have a pain in my abdomen. I have a pain in this area. You cannot say the right side of the duodenum is the pain location. It is localized, it is not localized. And there are several examples of the visceral pain, such as, for example, pain that we have in the kidney stone, pain that we have during the spastic contraction that happen in the intestine, or pain that is happening in the gallbladder distension because of the stone. These are pain in the viscera. Therefore, we have visceral pain, deep pain, and superficial pain. And when I will talk about the visceral pain in more detail later on. And let's wait. When the nerve fibers are activated, they enter the spinal cord. At the spinal cord, they make the synapse with the second nerve, second order neuron. This synapse is very important. This synapse is the synapse that sends the pain stimulus to the second neuron. Sometimes we use some drug to stop the pain, not aspirin and ibuprofen. Drugs to stop the conduction between the first neuron and second neuron. And you know that morphine is the most potent pain killer or pain inhibitor. Morphine. And what do morphine for us? Stop this conduction. In fact, nociceptor is activated. It come to the spinal cord, but in the spinal cord it is not able to stimulate, or the strongness of the stimulus to the second order neuron is being inhibited. And by this reason, we say that morphine is a pain killer. Another way to stop the pain is to block the depolarization of this neuron. You know that anesthesia, in local anesthesia, we add some lidocaine, for example, in your skin. And this area of the skin do not generate action potential. There is a damage. For example, I cut your skin, but you do not feel. You know why? Because the nerve fiber do not generate action potential. There is a damage, There is activity in the nerve ending, but nerve ending do not generate action potential. Therefore, local anesthesia such as lidocaine that you use, for example, in the dentistry, or when you have a, say, for example, suturing in your skin. This is conduction, stopping of the conduction of the action potential. Okay. This synapse is very important. Sometimes make the level of memory of the pain, particularly when it is more extremely active. This synapse will be facilitated and therefore make the memory of pain, and sometimes it brings some problem. Pain has two types. We have two types of pain. One is the fast pain or acute pain, and another is a slow pain. Acute pain is the pain that we feel at the beginning of the symptoms. For example, you are tapping your skin by a hammer, and suddenly you feel a pain. This pain is very sharp and high intensity. But then, 1 hour, 1 minute, 2 minutes, 3 minutes, 1 hour later, then this sharp pain will gone, and the pain will remain in your hand. That is not very sharp, but it's frustrating, and it is continuous. This is named as chronic pain. Sometimes remain for several days, or several hours. You see that the fast pain use large fibers to conduct the information, and use larger myelinated fiber to conduct information. Therefore, they send the information a little faster. And slow fibers use C fiber. Slow pain use C fibers. I told you that C fibers are unmyelinated. They use low level of energy. Therefore, they can remain active even when the tissue has lower oxygen available. And this is the two parts of the pain. And I told you that A delta fiber are myelinated, fast conducting neuron. They are responsible for sharp, fast, and highly localized pain. But C fibers are very thin, unmyelinated. They are slow conducting, mediate a slow down, and more diffuse type of the pain. Okay. And now, and this is showing the situation that I told you. Both fibers are activated, sent to the spinal cord into the brain, and this is showing the speed of the nerve fibers. The A delta have 80 meters per second, but unmyelinated nerve fiber is slow pain, just 0 point, less than half a meter per second. And you see that these fibers are converging in the spinal cord. They make connection with the nerves in the dorsal root of the spinal cord. And then after this connection, this synapse is formed, then they will cross to the other side of the body. Let me to say here, I have some slide later, but let me say here. As you can see, these are the C fiber and A delta fiber that send the information of the pain. But at the same time, we have a beta fiber responsible for touch sensation. And they try to inhibit the nerve fiber that is activated by the pain. When A beta fiber are activated, they try to inhibit the pain. And this is named as gating theory. All of us have experience. When we have a pain, we try to make it make a massage, or try to move it to stop the pain. Everybody has this, okay? You burn your hand and you try to or massage it to remove the pain. You know why? Because when this A beta is activated by this movement or this massage, this inhibits the nerve, and therefore we feel less pain. Okay? And you know it is working in the animal. Also animals, when they have pain, they can try to lick the pain, the area, they try to move the area, they lick to stop pain. It is not stopping the pain completely, but lower the pain intensity. This is named as gating. And this is the reason that you know sometimes we use massage therapy or acupuncture or even electrical stimulation. In some severe type of the pain, headache, we stimulate the nerve fiber of the trigeminal nerve, and this will inhibit the pain. This is showing the entry of the C fiber or a delta fiber into the spinal cord, crossing to the other area, other side, and then use the anterolateral pathway to the higher center of the brain. Okay. When the pain enters the spinal cord, they use different pathway to the brain. In fact, I can say that a copy of information went to the thalamus like the other sensation. But some other copies are being also sent to other area of the brain for the different reasons. One copy or main copy of the information is sent to the thalamus, and you know from the thalamus to the cortex. And this makes us aware of the pain. This allows us to know about the pain. This is very clear. It allows us to know about the location of the pain, where it is coming from. I have a pain in my, for example, right hand, left hand. What is the reason? How is the intensity? It's more intense, less intense. This is the pain pathway, pain pathway to the cortex. And you know, if we are aware of the cortex, of the pain, it is because of this pathway. It is named as a spinothalamic tract. The name is very clear. From the spinal cord to the thalamus to the cortex. And it mainly use, this pathway used to send the fast pain, the burning pain that we have at the beginning of the pain. But what about the other copies, other pathways? One pathway is spino-reticular. From the spinal cord, signals are being sent to the reticular formation. Who know about the reticular formation? Reticular formation is responsible for balancing the sleep. It's responsible for the cycle of sleep and awakeness. Every time that reticular formation is being activated, we are not able to sleep. And this is the balance between the activity and activatory and inhibitory factors. Now pay attention. A copy of the information from the pain that will come to the spinal cord will go to the reticular formation, particularly the slow pain. You may say, what is the importance of this pathway? When we have a pain, you say, last night I have a headache and I was not able to sleep. Everybody has this experience. I have a pain in my leg, I was injured, and I was not able to sleep at all. Do you know why? Because the pain is sent to the reticular formation and activate the reticular formation and do not allow the sleep. You may say, what is the importance? Because when we have a pain, we should not sleep. We should remove the should remove the reason for behind this pain. If I have an injury in my leg, for example, there is an injury and there is bleeding, I cannot say that sleep, inshallah, tomorrow morning, I will think about it. Let me sleep. It may kill you. If I have a pain in my stomach, it may be because of poison. It is not wisdom to say, let us sleep until tomorrow morning. Pain do not allow you to sleep. Sometimes you will have some patients that are coming to you and say, it is 2 days, 2 nights, I was not able to sleep. It is working because the pain is sent to the reticular formation, and you know it is protected. You should not sleep when we have a pain, particularly unknown. Sometimes you will say that I had a pain in my, I have a headache, and I used to have a headache every 1 week, one time a week. I know about the pain. I know. Therefore, brain will consider it, and therefore sometimes you can sleep, but not normally. But when you have a pain and you are not able to sleep and use medication and pain stop, you say, "Yes, I was able to sleep deeply." You know why? This pathway is stopped. I hope everybody understands the importance of spinal reticular pathway. Another pathway is a spinal mesencephalic tract. You know that in the mesencephaly we have one area named as periaqueduct gray matter. And periaqueduct gray matter is a center that regulates the intensity of pain locally, centrally. This periaqueduct gray matter send the information back to the spinal cord on the synapse that I showed you, and inhibit the pain enter into the spinal cord. In fact, I can say that when the pain enters the brain, it activates the mesencephalic pathway and then try to inhibit the pain or control the pain. This is very important. You know, sometimes this system is working. For example, during the labor. You know that labor, the intensity of labor pain is most intense pain that we can imagine. But the mother is tolerating, and it's no problem. How it is possible? How this very severe pain will be tolerated? Because the brain itself intentionally stops the pain or lower the pain intensity. Or sometimes that I will tell you that we have a situation named as stress-induced analgesia. When you are in a stressful situation, sometimes we do not feel the pain. We feel the pain only in lower intensity, not in actual size. For example, in the battlefield, a soldier is being injured. A piece of the muscle is being destroyed. There is bleeding, but the soldier is escaping. The soldier do not remain on the ground and say, "Wow, wow, wow, I have a pain. Someone help me." This is a battleground. If you do not escape, another bullet will hit your head. Therefore, you try to escape from this area. Transiently, this pain will be suppressed and allow you to escape from the battlefield. When you get in a safe area, then the pain will start. This is stress-induced analgesia. In the sport teams, you know that some sport players, for example, football players, are hurted. But because sometimes they are at highest state of energy and stress. What is going to happen? They continue their playing until the end of the match, and then they found that one tendon was destroyed, and you were not aware of it. Sometimes, for example, in the accident, a person injured in an accident and say, "I have nothing. Let me find out what happened to my car." And then everybody say that you should remain. You may have it, for example, bone broken. They say, no. This time, because of the stressful situation, pain is suppressed. And one pathway that suppresses the pain is the mesencephalic pathway.
Even if some bikers have crashes, and they get up and walk normal and then drop down in some seconds.
Again, the soldier also may try to escape, but the severity of the injury will not allow it, and then soldier will die. Adrenaline is working because to help the blood pressure not to drop because of bleeding. Adrenaline start to increase the heart rate to make the blood flow to all the area available. On the other hand, cortisol will work to allow the blood glucose to be up. All these factors. Thyroid hormone is working to increase your metabolism. All these factors are working. But the main factor is that at that time you should ignore the pain. This is stress-induced analgesia. And you know, this pathway also sends some pain signal to the limbic system. Limbic system that generate the sense of the emotional part of the pain. You know that pain has an emotional response. You are more susceptible emotionally. Sometimes you cry, sometimes you are stressful. This is because of the limbic system that is activated. Another pathway is cervicothalamic is the main is a pathway that send the pain from the upper part of the neck and head to the brain, and it is the same with the spinal thalamic. And finally, we have a spinal hypothalamic pathway. Again, everybody has experience. When you have a severe pain, you say, "I have no appetite. I had a severe pain last night, and I was not able to eat and drink even one glass of water." In fact, when hypothalamus receives this pain sensation, the viscera will change. Our visceral response will change. Sometimes severe pain will generate nausea and vomiting because of the hypothalamus. I'm sure some students here have this experience, that you have very severe pain and have a sense of nausea, vomiting. Everybody in this class have experience with having pain and not able, you say, "I'm not able to eat anything. I have no appetite." This is because of the spinal hypothalamic pathway. Spinal hypothalamic pathway also change the heart rate, also affect the blood pressure. What is the effect of blood pressure, pain on the blood pressure? Sometimes it increases the blood pressure. In severe pain, it may decrease the blood pressure even to coma. And this is showing the ascending pathway that we have for the pain. And this is important. Let me tell you, at least I have 2 to 3 questions from this slide and this pathway. You should know spinal thalamic, spinal reticular, spinal mesencephalic, spinal thalamic. What is the function of each of them separate? Okay. This is showing the spinothalamic pathway from the spinal cord in the anterolateral pathway to the pons, medulla, pons, and then thalamus, and then to the cortex. And spinal reticular formation again in the spinal cord. In the medulla, this affect the reticular formation. A copy will activate the reticular formation of pons, then thalamus, then cortex. About the spinal mesencephalic spinal cord to the medulla and then to the periaqueduct gray matter. And periaqueduct gray matter send the descending pathways, lowering pathway back to the spinal cord and inhibit the pain. And make it possible for the brain to control the pain. And this is another shape. Spinal hypothalamic pathway, spinal hypothalamic pathway that send the information to the hypothalamus, limbic system, reticular formation, and also the thalamus and then to the cortex. When the pain fibers enter the spinal cord and then make the second or the synapse with the second order neuron, they will come to the different area of the spine, to the thalamus. You see that ventral basal complex, receive also from the touch. This area receive information from the touch, pain and touch. And if you are able to localize the pain, it is because of the touch sensation. When you have a pin, for example, a pin enters your skin and you have a pain, at the same time, touch sensation also will be activated and sent to the thalamus. And we use this information to say which part of the skin is being injured. Localization is important. And then send the signal to the somatosensory cortex, and then we are able to detect all the part of the pain. Slow pains also synapse in the spinal cord, then relay to the midline nucleus of the thalamus. They are different. They are coming to different type of the thalamus, and then to the limbic system. I told you about the emotional response that we have. This is responsible for the emotional and motivational response that we have in the pain. And they are very important also for the interpretation of the pain. As I told you, we have a pain that is coming from the viscera. You know that our viscera, such as the gastrointestinal system, heart, vascular system, kidney, bladder, all are these viscera. And these have receptors for the pain. Also, we have some area in the viscera that have no pain receptor. Therefore, they are pain insensitive. Let me say, for example, lung tissue itself is pain insensitive. Even cutting the lung tissue do not generate. The heart is, the brain itself is pain insensitive. It has no pain receptor. But some area have very high density of receptors. For example, cornea of the eye. In this class, who have experience with eye surgery, such as LASIK, to remove the glass? Nobody. Those who have eye surgery know this is extremely painful. Or you know that the pleura that is covering the lung have high density of nerve fibers. Therefore, they have high degree of pain. In the intestine, instead, there is numbers of the pain receptor, but the number is not very high. Therefore, if we cut a piece of intestine, the pain is not very severe. instead, when the pain, when a large piece of the intestine is being affected, for example, it's distended, it generates pain. One characteristic of pain sensation is that it is one characteristic of pain sensation, that visceral pain sensation, is that it is poorly localized. You know what does it mean? It means that visceral pain is not like somatic pain. When you have a somatic pain in your skin, you can say which part in the skin is being painful. Exactly. But visceral pain is not. You say somewhere in my abdomen area have pain. Can you tell me where it is? You say no. It's pain coming from right side to the left side. But you know, we have not a damage from right to left. There is a part in the viscera that have pain. We are not able to localize it exactly. This show the poorly localized nature of the pain. Particularly when we are talking about visceral pain, there is another phenomenon named as referred pain. Sometimes visceral pain, not only that it is not localized correctly, but it also refers to another area. For example, you say, I have a pain in my chest wall, in my shoulder, in my neck, in my hand, in my arm. When I ask you where is the pain, you say it is diffuse. This is named as referred pain. And you know that in the viscera, such as intestine, in the intestine, stomach, gallbladder, bladder, kidney, the main reason for the pain is distension. Sometimes it is because of the ischemia, low oxygen concentration, and also sometimes because of chemical stimulus. For example, when a person is coming to you and say, I have a pain in my heart, it is because of the ischemia. One vessel is being closed, blood flow to the heart is stopped, therefore ischemia generates pain. Or when a patient is coming to you,
Can I take 5 minutes?
ايوه مجد.
طلاب بس قراءة التبليغات راح تتبدل، لأن دي يعني بها أكثر من تداخل راح يصير، فقراءة التبليغات راح تتبدل. بالنسبة لجروبكم تواصلوا وياي 8 ساعات كل جروب قراءة التبليغات، وتواصلون وياي يضيفكم بالقراءات مال التبليغات مالتنا الخاصة بي. هاي واحد، اثنين بالنسبة لمواد الكورس الثاني، كم شخص أقدر مال الكورس الثاني هنا؟ بالنسبة للمواد
I told you visceral pain therefore is poorly localized. It is because of the ischemia, distension, or chemical stimulus, and it is also referred. And as I told you, this is showing the most cause of the visceral ischemia, chemical stimulation, spasm also. I forget to say. A spasm of a hollow, vicious, over distension, and I told you also about insensitive viscera, such as brain, such as lung tissue, that they have not a pain receptor. You know, lung covering, that is pleura, contain lots of receptors, therefore it is painful. But lung tissue itself has no receptor. Brain also is like this. The brain itself has no receptor. We can cut the brain and there is no pain. But the meninge that is covering the brain is extremely sensitive to the pain. Okay. Now you know know that pain in the viscera is coming to the spinal cord. And when they come to the spinal cord, there are the visceral afferent are the AD and C fibers, and a large number of these receptors are not active normally. Just they are being activated when there is an inflammation and also there is a problem. Okay, now we have a process named as referred pain. What is referred pain? The patient come to you and say, doctor, I have a problem, I have a pain in my left side of the chest, this part, left shoulder, left arm, in this area of the neck, and you get worried. You say, hey, it's very dangerous. It may be your heart. Why? When we have a problem in the heart, there is a pain in the left arm. This is a referral of the pain. Referral of the pain. Pain is referred to another place. And what is the reason? When this person has a heart disease, heart problem, ischemia, MI, myocardial infarction, or angina, these fibers come to the spinal cord from the heart. At the same time, we have some nerve fibers, nociceptors, that are coming from the shoulder arm. They are coming to the same site in the spinal cord, and therefore they are converging on the same route. Brain will see this pathway. When brain sees that this pathway is activated, brain have a misunderstanding that this pain is from this part or this part. And therefore, because brain is not able to detect where is the source of the pain, generally it refers to the skin. And therefore your patient will say, I have a pain in my left arm, left neck, shoulder, but you know that this type of pain is a referred pain from the heart. And immediately you say, please stop in your field, do not move anymore, let me to bring some oxygen for you, let me to give you a nitroglycerin drug that open the heart, and you should immediately please record the electrocardiograph to see, because you know this pain is referred. Unlike the pain that we have in the somatic sensation, when you have a somatic pain sensation, you say I have a pain, and exactly you say this side have a pain. If your patient come to you and said, I have a pain in my shoulder, and just this shoulder is painful, you say it's your shoulder. But when he said that I have a pain in my shoulder, in my arm, in my neck, in my chest, it shows that this is not localized, and therefore it is a referred pain. I hope everybody understands the mechanism behind the referred pain. And you know, it is not just for heart, it is also for other viscera, such as liver, such as stomach. You see, a stomach also refers to the skin. When we have a stomach pain, we say, here we have a pain. And you know, because it is the same area that really a stomach is placed, when we have a pain in this area, we know that it's a stomach pain. But sometimes heart is here, but here we have the pain. You know that esophagus, have a look at the esophagus. Esophagus have overlap with the heart. I want to say, when we have a shoulder pain, left arm pain, it may be esophagus, because they are overlapped. Lots of time, you have patients that come to you and say, I have a pain in my shoulder, in my heart, and you say, it's a danger. It may be your heart. When you check, you see that heart is normal. Then you say, then okay, it was your esophagus. And you know that according to the protocols, we consider the first priority as heart. Because you know, we do not say, you have a pain in your shoulder, it's your esophagus. No, nothing. If it was heart, it's dangerous. We should rule out the heart possibility, then say, because they are overlapped. For example, another example is the appendix. Those who have appendix pain, this is appendix. You see, they are covering they refer to the area, perineal area, and in the center area of the abdomen. Pain in the liver and gallbladder will be referred to the right side of the abdomen area. All these pain will refer to the skin. Most important one was the heart. If somebody, this is also true. This is also true on the other side. Some patients come to you and say, Doctor, I have pain in my heart. Then we ask where you have a pain. They say, like exactly this. When a person told you that I have a pain in my heart, and they just refer to one point exactly, this is the pain, say it is not your heart. Because heart is not localized, it is diffused. We do not get worried if you told me that I have a pain exactly here. What about here? No. What about lower? No. Just this. It may be because of the muscle. Okay? The patient believes that the heart is a problem, but it is not. When it is exactly localized, it is not. If your patient comes to you and says, I have a pain in my stomach, exactly here, this is not the tissue, the visceral. Because when we have the real visceral pain, it should be referring to diffuse area. Okay? And I told you about the mechanism behind it. This is showing the convergence theory. This is convergence theory. Pain from the viscera, pain from the skin are coming to the same pathway and then stimulate the same pathway. Therefore, brain is not able to distinguish this from each other. I told you about the gate theory. Gate theory says that we have synaptic junction between the peripheral nociceptor fiber and dorsal horn cell in the spinal cord. And it has plasticity. I told you that when other nerve fibers, such as A beta fibers, are activated, they can stop the pain and generate analgesia. Analgesia means reducing the pain sensation. And for this reason, I told you that when we hit our hand, we try to move it, to massage it, and it was because of the convergence of the gate theory. The gate theory is activated by simultaneous activity in other sensory stimuli, the massage, and also descending nerve fibers that are coming from it. Application of the pain application of the pain gate theory. I told you it is like the massage, acupuncture. Hence, those who have severe headache can be treated by stimulation of the nerve fibers, sensory nerve fibers. And you know that body have some mechanism to control the pain, as I told you, such as natural childbirth techniques, that you know release lots of morphine. In the mother, at the labor, lots of morphine is released in the spinal cord, and therefore, mother do sense the pain, but not severe pain. Because you know, when the pain is very severe, it may stop, it may cause even unconsciousness, coma. I told you about the mechanism to stop the pain. Sometimes at the beginning of the stimulation, sometimes with drugs that stop the nerve activity, action potential, and sometimes, for example, is using morphine as the treatment. You know that morphine is the most powerful painkiller that is used and is stopping the pain, and therefore we know it as pain killer. One another pathway that stops the pain is from the center and from placental matter. As you see, it comes to the nucleus cellulose and also to the nucleus magnus raphe, and then to the spinal cord. In fact, brain inform the spinal cord to not send more pain sensation. I know about it. I want it to be controlled. But you should know one point. We have no adaptation to it. Nobody can say, I have a pain, let me to wait after 1 minute and then I will forget it. Until the time that we have pain sensation is already. However, brain is able to control the intensity of the pain. And one reason was I told you about the stress-induced analgesia. When we are in a stressful situation, brain stop the pain in the spinal cord, such as the soldier, such as the... And this is showing the synapse between the nociceptor and the second order neuron. And you see that a nerve is coming down from the brain into the spinal cord and release lots of endogenous morphine. You know that morphine, we have some neurotransmitters such similar to morphine, and they are named as endorphin. They are working like morphine. And when they release, they stop the conduction between these fibers. And therefore, we sense less pain. But you should know, it is normal. Unfortunately, when we have uncontrolled use of morphine, then the receptor for these enkephalins and the endogenous morphine will be reduced. And for this reason, addict person do not respond to endogenous morphine. They use exogenous one. They try to use drugs. But normally, endorphin could be released. And you know that endorphin not only stop pain, but also increase euphoria, increase our sense of well-being, and sense of pleasure. It is generated by endorphin. Again, addict person are seeking this pleasure that use the drugs. This is the mechanism that works to lower the pain intensity from the center to the lower part. Okay. It's the time. You know, let me tell you another phenomenon. We have another phenomenon. This is also very interesting, named as phantom limb. Who knows what is phantom limb? And
Phantom pain?
Phantom pain.
Phantom
limb.
Yes.
And khiyali.
When you have a limb that is cut off, you
Yeah.
have
Feel the
sense of
pain.
but it is not there.
You have a pain in your finger, while the finger is not there. In those who it is cut they say that my finger is very painful, but we said you have one finger. This is named phantom limb اندام خیاله خیالی خیاله اندام خیاله وفي الخيال. There is no real, and the pain is also real. Sometimes it is very severe. Sometimes it is very severe, and those who have limbs that are amputated always complaining that my finger is heavily painful. What can I do? When I have a pain in my finger, I try to do massage, do something. But when it is not possible, available, what can I do? It is also true for the sensation. For this reason, it is not always phantom pain. It is all phantom limb. Phantom limb that sometimes they say that I feel something is moving on my finger. It is not painful, but it is moving. I think I feel someone is touching my hand. You say you have not hand. Your finger is not available. For this reason, it is named phantom limb. Why we have phantom limb? Why we sense it is not hallucination? It is real. Why it is possible? How it is possible? It's very simple. When there is a nerve fiber is starting from the finger, come to the spinal cord and then to the brain. When the hand is being cut, the nerve fiber from this part is available until the brain. Therefore, every time that this ending is being activated, brain will consider it as a finger. The finger is not available. But because the whole pathway is not removed. And for this reason, it is a strongly miserable situation. A person is at a very bad situation when they have phantom pain, phantom limb. Imagine on your finger something is moving, but you are not able to remove it. It's extremely bad. Finally, we have two phenomena about the pain. I have 1 to 2 questions about this slide. Please pay attention. And this is hyperalgesia and allodynia. What about hyperalgesia? Hyperalgesia means when we have a painful area, for example, a burning. Now this area is very sensitive to pain stimuli. For example, if in a burning skin you put a pin, it is painful, but not very severe. But our response will be very, very high. In fact, I can say that sensitivity to pain is increasing, but to pain stimuli, not to touch stimuli. In the hyperalgesia, imagine this guy have hyperalgesia in the skin. When I touch by my finger, it do not generate pain. But if I put, for example, a light stimulus that is painful, this is extremely severe for him. Therefore, we say sensitivity to a painful, already painful stimuli is increased. What about allodynia? Allodynia is another thing. Allodynia means when the skin sensitive, because of the release of chemical at this area, sometimes the pain receptors are so sensitive that even without any damage, without release of any damage associated molecules, it generates pain. For example, you have a sunburn on your skin, and then when you put your clothes, you say that these clothes also generate pain. This is not painful. This is just my clothes. It is not painful. But that time it will be painful. We say normally non-painful stimuli such as clothes will be painful. This is allodynia. And allodynia also is very, very severe. Sometimes you say that you have some patient that say, my skin is, for example, because of bear. I am not able even to take out my clothes. I should always take it out. I am not able because it's extremely sensitive. Sometimes they are moving like this because they say even movement generate pain. Movement is not pain. They try to do not move because they say even movement of clothes generate pain. And this is allodynia. Everybody understands the difference between allodynia and hyperalgesia. If I ask you about the difference and you wrongly answer the question, there is no chance for any excuse. I told you exactly what is the difference. And these are the cases that you will see in the hospitals, in your clinics all the time. Patients that are coming with hyperalgesia.